biceps tendon can reverse profound pseudo-paralysis in patients with irreparable rotator cuff tears. Single center retrospective study.
Over to you, Dr. Ayyappan.
Thank you, sir. Respected teachers, senior colleagues, judges, friends. I'll be speaking on the hybrid superior capsular reconstruction technique, which is a combination of the fascia and lata graft and the long head of biceps used in irreparable rotator cuff. We are postulating that this can reverse the pseudo-paralysis in patients with irreparable rotator cuff. The single center study done at Manipal Hospital, Whitefield Bangalore. So coming to the background, the pseudo-paralysis is a significant finding in massive irreparable rotator cuffs. So we call it pseudo-paralysis when the patient is not having an active forward elevation of 90 degrees. There is also a definition of 45 degrees, something called as profound pseudo-paralysis, described by Wakar. So characteristics of an irreparable tear are tendon retraction, elasticity, muscle atrophy, and fatty infiltration. Fatty infiltration is graded by Gautier. So higher stage 3 and stage 4 shows that it is an irreparable tear. And a higher Hamada grade shows that it is again an irreparable tear. So again, this is a modified flathead classification showing a significant retraction, a stage 3 retraction showing that it is irreparable. So what are the options in front of us when we have an irreparable tear? We can have a patch graft surgery, we could have a muscle transfer, we could have a partial repair, we could have repair with augmentation, biceps rerouting, and lastly and majorly the superior capsular reconstruction described by Dr. Vihata, where a fascial lata graft is introduced into the subacromial space attached to the glenoid at one end and the GT on the other end. So it is shown that it decreases subacromial contact pressure, increases acromihumeral distance, and restores the glenohumeral compression. Biomechanically, it is shown that an ideal graft thickness is more than 8 mm and the position to fix it is between 15 and 45 degrees of shoulder abduction. Our modification to the existing technique of Dr. Vihata was that we cut the long head of the biceps with the biceps groove, transferred it to the anterior-most position of the tear, and then we did a fascial lata graft on top of it. The advantages were that there is a reduction in the fascial lata graft required, the amount of graft which is required, and we had to double it instead of tripling it. And long head of biceps acts as a natural depressor of the humeral head. There is a natural attachment of the biceps on the glenoid. And lastly, it definitely decreases the requirement of the fascial lata because totally the graft thickness increases in the subacromial space, especially anteriorly. This is the technique which we do, and so this is an arthroscopic view. We can also already see that the biceps has been cut, and I have already taken a suture in the long head of the bicep. The suture has been put. It has been tied down, and then we take a measurement. That is a measurement of the graft taken, and then we take an adequately sized graft. It is prepared outside the fascial lata, and it is shuttled into the joint, and it is fixed like this on the GT as well as on the glenoid, and the remaining cup is attached on the top of this. The aim of the study was to analyze the clinical and the radiological outcomes of this particular technique, the hybrid technique. In materials and methods, 10 patients were included in this retrospective study. It is a single center study. Period was from December 2020 to December 22. All patients were operated by a single fellowship trained surgeon. Maximum follow-up period was for 24 months. Inclusion criteria was irreparable tears, preoperative active forward elevation was less than 45 degrees, that's a profound pseudo-paralysis described by Burkhardt, intact and repairable subscapular tendon, and radiographic classification Hamada between 0 to 3. Contraindications was irreparable subscapular tear, absence of the long head of biceps, any Hamada classification higher grade showing significant glenohumeral arthritis, nerve injuries, and infections. The parameters which we assessed were the VAS score, ACS score, subjective shoulder evaluation. Radiologically, we checked for acromihumeral distance on the X-rays, preoperatively, postoperatively, and re-tears were assessed by the Sugaya classification. ROM was checked, active forward elevation, flexion angle was checked, and external rotation was checked preoperatively and postoperatively. MRIs were done at the end of 1 year. This is a typical case we had. The 56-year-old male patient, history of fall 7 months back, significant retraction and proximal migration, profound pseudoparalysis. This is the preoperative X-ray and 1 year follow-up X-ray. The results were the 10 patients in the study. The mean follow-up was 16 months. 8 out of 10 patients began satisfactory increase in postoperative active forward elevation. Graft healing was noted in 7. 2 patients required reverse shoulder replacement due to poor clinical outcomes. Demographics, more of male patients, and distribution was in most of the patients were between 60 and 70 years of age. Graft healing was noted in 7 out of them and non-healing in 3. Most of the patients were in higher Hamada grades, that is Hamada grade 2 and 3, and Gaudier grades, that is fatty infiltration grade 3 and 4. This graph shows a significant increase in the ACS scores, 41 to 79, and economic humeral distance increased from 3.3 to 7.7 millimeters. Our WAS score was also increased, that is almost all patients had a significant reduction in the pain. The subjective shoulder values also significantly improved from 36 to 90, and forward flexion angle, a huge improvement from 35 degrees to 145 degrees. Satisfactory external rotation from 25 degrees to 40 degrees. Discussion. Results of the current study confirm that the hypothesis we had initially, that a profound pseudophagosis at less than 45 degrees, even that can be reversed by a hybrid SCR. Distillation of a stable fulcrum via the addition of a passive biological constraint effectively optimizes the post couples about the shoulder, thereby enabling more normal kinematics. Improvement in the active forward elevation after the SCR is much better than even the reverse shoulder. Hybrid SCR, that is a combination of facial lateral graft with the LHP, provides better improvements in healing rate of the graft when compared to a conventional SCR. The healing rate in a conventional SCR according to studies around 62, ours is like 70%. Improvement of Gaudier grading is because 1 year follow-up MRI showed that there is definite improvement in the Gaudier grading with lesser fatty infiltration. Anchoring of the LHP at the GT insertion provides a natural constraint to superior migration of the head. Limitations were retrospective study, small study group. Arthroscopic hybrid SCR gave an outstanding pain relief in these patients. Reinforcing the facial lateral definitely improves the outcomes. In conclusion, SCR used with a hybrid technique, that is a combination of facial lateral with the long head of biceps, provide good rates of return of shoulder active forward elevation in patients with profound pseudophagosis. Thank you.
Thank you, Dr. Ayyappan V Nair. Any questions?
Sir, I can't hear you.
Are you rerouting the biceps or are you motorizing the biceps? Because once you
Yeah, we are cutting the biceps at the bicipital groove and shifting it to the anterior side of the, that is, even if the anterior part of the tendon is intact. So normally we cut, so I cut it in the groove, push it through the groove into the joint and pull it out of the anterior aspect of the tendon and fix it anteriorly. So basically denotomized it. So it is a reverse bicep tenodesis.
The follow-up is 16 months, average follow-up.
Average, sir.
Average follow-up is 16 months. Do all of them have this range of motion preserved till 16 months?
Yes, sir. Okay, so because we find that okay, once they have achieved, all these patients have achieved, they achieve their maximum, that is this 145 degrees or whatever maximum range is achieved by around 6 months. After that it persists. We don't have a deterioration. But patients, in 2 patients we had to go for a reverse because of poor follow. Because we know by around 6 months if they're going to improve or not.
All types of repairable tears you advise this in this age group?
Sir, definitely it's more than, sir, I feel that it is more than an age group distribution.
What age that time?
It is basically, if it is a irreparable tear, definitely this is a good option. Because it is an arthroscopic technique, definitely with comparable result to a reverse shoulder. So definitely I think it's a very good option.
how common is it to find a normal bicep with such a retracted and long-standing?
Yes. So what happened was, that is why we have to take cases. We have done more of SCRs, but we could find, because as what you said is absolutely right, because there is an anterior scale, and definitely the biceps are damaged. So we could find only 10 patients in this 2-year period. So whenever we have, it definitely is a good choice.
Those with the reasonable biceps only you will be doing it.
Sir?
Those with the reasonable biceps.
Yes, sir.
Good
Because
point.
even if the biceps, even if, because sometimes we cut out the biceps. We do a biceps sternotomy.
Yeah.
So even if the biceps is inflamed, we can still use it here. Even if the biceps is partially damaged, also still we can use it here. Yes.
Thank you, sir. The next speaker is Dr. Sujit.